Hello, everyone. I'm John Camisi,
I'm Larry Clark.
and we're here today to share with you this presentation, Bioactive Restoratives, Giving Teeth What They Want.
Before we start, we want to say hello to our friends in Houston, in Florida, and all the islands that have been ravaged by the storms. And we just want you to know that our hearts and prayers go out to you.
Yes, indeed. It is indeed a great privilege and a pleasure to be doing this presentation with you tonight, Larry. It's going to be a lot of fun.
Me too.
5.7. This is a really interesting number, and no, it's not the A1 count as far as your glucose meter. We know that everything below 5.7 is a really great reading, but that's not what we're going to be referring to this evening, of course. 5.7 refers to the average service length of tooth colored restorations found by the NIDCR. And this is a really shocking and a really scary kind of reading for me, because most restorations that I want to last a heck of a lot longer than 5.7 years.
Me too.
The mouth is a really interesting entity. It's beautiful in so many different ways, but at the same time, it's pretty much a battle with a lot of activity going on with the acids and bacterias and dryness that can set up because of various xerostomias, etc. And it's a constant challenge for most of us in the dental profession to really figure out how to help keep the mouth healthy and keep our patients healthy at that situation. Decay and oral disease is multifactorial, especially the decay factor with bacteria, what happens with our diet, natural issues, of course, like I was saying, dry mouth, grinding, clenching, and you put all these factors together and it becomes a real serious problem for we as the clinicians and, of course, for the patients itself. So we're here to talk about what I like to call the battle of the bond. And the literature nowadays is filled with all kinds of issues. And clinically, you and I are seeing situations very much like this, as I saw in one of my patients in my clinical practice. It devastated me to realize that this patient only had these restorations done a few years earlier, and they were already in it made the patient very unhappy, and certainly me as the following clinician had to manage this very unhappy, because I knew that we had some serious trouble on. The literature, as I was indicating, is filled with a preponderance of data showing us that our current adhesive model and our current adhesive systems have a major problem. They are failing, they are breaking down, they are just not doing it as well as we should. And the article on the bottom left, Long-Term Durability of Dental Adhesives by Arzu Tesregiomutale, is a really important one that I want to just briefly talk about. And in this article, Arzu basically says that the progressive loss of dentin bond integrity and reduction in bond strength has been extensively reported, as we just illustrated. And it's attributed partly to the hydrophilic nature of contemporary adhesives, causing unwanted water absorption, phase separation, and resin leaching. That's a really important aspect that we have to think about. In addition to that, we have this endogenous cholinogenic enzymatic activity that's also breaking down and hydrolyzing the collagen. And that's all because of the hybrid layer formation that we are creating with our current dental adhesives. Water is intrinsic. It is necessary for life. We're made up of a great majority of water. Without it, we can't live. And water is important because it's also needed to prevent the collapse of the dentin collagen fibrils, enabling the dentin bonding agents to permeate and try to create tissue engineering hybrid layer. If you don't have water, you can't create the hybrid layer. And we know from the studies that water is always present within the dental tubules. However, since water is always flowing outward from the tooth, and we do need a dry substance eventually to be able to bond to, we seem to have the problem developing with our hybrid resin adhesive. In this paper by Saro, Watson, and Banerjee, they illustrate diagrammatically the various grades of hybridization that can potentially form. In an ideal world, a grade 1 type of hybrid layer would form. However, according to Saro and the others, that's really never going to occur in real life. At best, we may be able to get maybe a 2, but traditionally and typically, we're going to pretty much find grade 3 and grade 4 hybrid layers being created because of the moisture and the water found in the dentinal tubules, even after we have properly followed manufacturer's directions on how to try to create the hybrid layer. In this paper by Annalisa Mazzoni and Bresci, they talk about the role of dentin matrix metalloproteinases in the caries progression and bond stability. And it's very important to understand that there's a constant enzymatic breakdown and reaction occurring because of the enzymes are entrapped within the hybrid layer during the resin infiltration process. And the acidic bonding agents themselves, whether they're self-etch or total etch, activate these proteases and cause the bond degradation that you and I see, and that we seem to be finding in the NIDCR studies of 5.7-year average lifespan of dental composites. In another paper by Annalisa and Bresci, they show this hybrid layer degradation in the zymograph, which is really fabulously illustrative. On the lower left side of the upper image, you see this green layer with the D, and then you see a line with an arrow pointing with HL. Well, the D is the dentin, and the HL line is the hybrid layer, and the R is the resin, as zymograph. The green represents the enzymatic breakdown that is occurring and the body's response to the hybrid layer. The body, the dentin, the tooth, essentially is rebelling against the acid. An acid attack, according to the dentin, is a bacterial attack that can otherwise cause problems to the tooth. So the body is defending itself, not realizing that what we're trying to do is protect it, but it's still creating a biologic activity that is trying to defend the tooth. Now, there's also a problem, as in this article by Van Merbeck, regarding the lack of buffering in composites, which creates more of a challenge and more caries susceptibility that enables a higher secondary caries rate to occur than we'd really like to see. So our materials, not only in the hybrid layer, are creating problems, but our traditional composite materials themselves are not helping because they are enabling secondary caries activity to occur. And interestingly also, the oral biofilm also has a major effect on what we're trying to do. It seems that the biofilm is able to negatively affect the bond strengths of our self-etchant adhesive systems within the dentin. So there always seems to be some kind of variable that is negatively influencing what we're trying to do in the way that we're trying to therapeutically help our patients. And this article by the Tay and Pashley group is really remarkable to me. It talks about bonding of universal adhesives to dentin, old wine in new bottles. And in their conclusion, they state, the increase in versatility of universal adhesives is not accompanied by technological advances for overcoming the challenges associated with previous generations of adhesives. Therapeutic adhesives with bioprotective and biopromoting effects are still lacking in commercialized adhesives. And that's a really huge statement for me and probably also for you. Let's also look at some other factors that come into play when we're trying to restore with our current traditional adhesive materials and bonding agents and composites. We have to consider several factors, including improper etching of the enamel, lack of proper isolation, poor curing light energy, and improper use of materials, such as using a regular composite as a bulk fill. They're not designed to do that. And every time that they're used in that way, we create problems that really aren't intended to be there. And I think that most important, the biggest challenge that we all have in everything that we do, of course, is the human factor. Many of us follow directions, many of us don't follow directions. And the reality is that the information for use as to how to use a product properly is sometimes discarded. And I've done it in the past, and I'm guilty of knowing how to do it better than the instructions do, and have found my own amount of failures in my clinical practice over the course of time. But I have also found that if I'm using the instructions properly and using the products according to directions, I'm going to get a better result long term. But the human factor is certainly a component that we have to think about. So let's talk about bioactivity. It's a really giant buzzword, and I've been writing a lot about it as of late. It's been a very important part of my life, especially as I transition now into being an assistant professor at Medical University of South Carolina. I want to look more at this as we go forward in various studies that we hope to provide. Bioactivity originally was introduced in 1969 and defined as a material that elicits a specific biologic response at the interface of the material, which results in the formation of some kind of a bond between the tissue and the material. But a few years ago, Steve Jeffries really helped to redefine it based on some work that he did, and it's really some remarkable work at that. And Steve recoined the phrase bioactive as a material that forms a surface layer of apatite-like material in the presence of saliva or a saliva substitute. And basically, the precedent that he worked with was the apatite formation closure of marginal gaps in his study. And the study is really important because it shows, as illustrated here, whether or not the self-adhesive resins, the resin-modified glass ionomers, calcium aluminates, or the calcium silicates can close the gap that is artificially created, as illustrated on the left-hand side of the slide. So they created a gap and then put the material on the substrate to try to see if apatite could form over the course of time. The top three materials, even after 58 days, did not create any type of apatite. But we can see that the calcium aluminates and the calcium silicates, after about 20 to 30 days, really closed and sealed the tooth spectacularly. So that's a really exciting thing, and that's really what bioactivity is now defined as. Bioactive glass fillers have been shown to basically help to reduce the bacterial penetration into the marginal gaps also, because unfortunately all resins shrink, whether they're self-curing or light-cured. They all shrink. And I have seen advertisements for various materials out there that say that they solve the shrinkage problem. I'm sorry to say that the reality is that, in my humble opinion, all resins shrink. And I think it's scientifically been proven in that matter as well. My good friend, Dr. Josette Camilleri, who is probably the foremost expert on mineral trioxide use in the world, has really written this very fabulous book that I would recommend those of you who are interested in knowing more about MTA on how it works. And Josette, I had the pleasure of listening to a lecture that she gave at Turku, the biomaterials getaway that we had last year in Finland, and she at first irritated me. I couldn't believe that she was saying what she was saying, because it completely contradicted everything that I had believed up until that point. But as I listened to Josette, I learned. And it was a remarkable thing, because she understands, and she talks about Portland cements, mineral trioxides and tricalcium silicates. And she has observed how they work in nature, how chloride and sulfites and carbonation and efflorescence all changes the overall long-term ability of these materials to withstand the elements of the environment in which they're exposed to. And she said basically, just because a material forms a crystal doesn't necessarily mean it's doing what you think it is. So you can create this wonderful cement block and this cement structure, but over the course of time, something is happening to it. The material is doing something. The environment is doing something. And really, a remarkable statement, your material is changing and change is expected, but it may not be as predictable as you would expect. And I started to listen closer to what Josette was telling me. She says, what happens to our dental materials in the hostile environment of the mouth when they come in contact with blood, with the tooth structure, with other reagents and materials that we use to try to overcome the challenges in the oral cavity? And in some of her studies recently, she has shown that blood can really stop the antimicrobial abilities of MTA to really work well. So she really got under my skin. Just because of that, I've already said that part, sorry, must be in the next one. Let me go back there. Materials changing but might not be as we expect. My slide must have gotten mixed up. My apologies, folks. But reality here is that we need to understand that when our material is in the mouth, it may not be doing what we see it doing on the bench. And the circumstances in that issue might become more problematic. Let's go on to biomineralization, and this is a topic that I'll go briefly through, because biomineralization is how living organisms secrete inorganic minerals in an organized manner. They form this structure and properties. They take the inorganic solids deposited from the biologic systems, and they selectively uptake the elements necessary to create what they need to biomineralize. They form biologic appetite in a biologically controlled process, and the process produces a mineral that has a specific biologic function and structure, and that is what happens in biomineralization. A couple of years ago at the AADR meeting, the American Academy of Dental Research meeting in San Francisco, I had the opportunity to listen to Dr. Franklin Tay talk about how intrafibrillar collagen mineralization, biomineralization, can occur using specific types of amorphous calcium phosphates of the correct size and of the correct capability. And in the biomineralization process, what we're trying to do is take this demineralized collagen and remineralize it, giving it back in the appropriate way, the substrate and the building blocks to reform collagen. And now this illustration is one thing. We're actually able to see this in micrographs that have been done by other scientists as they go by. As they've done their work, and we can see in this how the amorphous calcium phosphate being used here is actually able to reinvigorate and regrow the collagen fibrils, so this way they can get back their elastic modulus and their overall ability to function as they were originally designed by nature. Also, we wanted to look at this paper by Gabriele Bruna, Salvatore Saro, and Marcello Giannini, in which it talks about the experimental bioactive biomimetic self-etchant adhesives that they doped with calcium phosphate fillers to try to create some kind of regrowth of this using a composite-like material that had a bioactive agent within it. And in these slides, we can see from A through D, the overall in A, the beginning of the biophosphates beginning to remineralize the extrafibrillar collagen, and then continuing on in B, and then in C, the phosphoproteins and the biophosphates are reaching deep within the collagen and creating a new invigorated fiber bundle. So biomineralization with the proper types of composite materials with the right types of resins and the right type of calcium phosphate agents can help the tooth heal and repair itself over time. Also, I was at a lecture and I saw this slide. It was presented by a representative from a major company in the dental materials world. And they were talking about what they saw as the next phase in the overall development of dental materials. And they wanted materials to be permanent, being able to withstand the occlusal stresses and, on the restoration. They wanted to be moisture tolerant, so this way we wouldn't have to worry about having a rubber dam or isolation present in there. They wanted to have decent aesthetics for all types of restorations. That it could be self-adhesive, so this way we wouldn't need any kind of special adhesive material at all. And even more interesting, they wanted to be bulk fill, self-cure, and potentially also light filled. And I'm sitting in that audience, and I'm kind of dumbfounded. And I said, gee, I think there's a material already available that does all of this. And I turned to a colleague next to me and I said, I think they're talking about Activa, because I'd been working with Activa for several years prior to this in my office and had found amazing results with it. And again, as this article that I had published back in the Dental Product Shopper, Dental Product Report several years ago, I was excited about this material and I adopted it immediately.
So John's been great to tell you what's been happening in the literature as we study the longevity of composites and what we're seeing as a cause of failure, and what we're realizing is that there's things that we can do. We just haven't been looking as research companies. We just haven't been looking in the right direction. And so now we see not just ourselves, but many companies looking towards biomineralization, bioactivity, if you will, to correct, if you will, as best as possible, some of the things that we're seeing. So about 4 years ago, we entered a family of products, all in the bioactive nature. A base liner and a restorative material, cement, and also a product for children primarily to mask silver diamine fluoride darkness. The cement actually was ready in those days, but we waited a few years until last year actually to bring it out. And I'm just going to share with you from hopefully as unbiased as possible what this material has shown us. We have a saying here that Activa is actually teaching us what it can do more so than what we thought. And so we're very fortunate. So we've done many, many studies. In fact, over 45 studies have been done regarding Activa at many universities around the world. In fact, those are all available at the website. And what we're proud of is also we have some clinical studies going. This one here is at Dental Advisor, and we also have one going with Dr. Jan van Dijken in Sweden, who's one of the foremost men in clinical placements of dental materials. And this is a copy of our 1-year data and our 2-year report, follow-up report of what we see as a 5-year study for Activa Restorative, and probably longer. And what you'll notice is that it's still getting very high ratings. There's little change, if any, between year 1 and year 2. And some of the interesting things is that almost 30% of the restorations that were placed in 100 restorations were done without an adhesive. When we first came out, we really tried to highlight that, and what we found out was we sort of made people afraid, not to use the bonding agent. And I just want to say today that it's okay to use a bonding agent with Activa, because subsequent studies done by Dr. Jerry Kugel at Tufts University has shown that the ions of Activa can go through even the more hydrophobic bonding agents that are currently available, or what many people call the universal bonding agents. So once the ions are on the other side of the bonding agent, good things can happen, which I'll be happy to illustrate in a moment. But what you're seeing is, the materials are lasting. They're wearing well. They look great. They're not staining at the margins, and so on. So we're very proud of what we're seeing clinically. And many of you out there have probably been using Activa for more than 2 years, and I'm saying you're seeing the same thing. So Activa has found a very popular place in bulk filling. And because of its injection molding qualities, as David Clark would say, you know, it has an unlimited depth of cure because it's dual cured. And the best bulk fill materials on the market are probably dual cured, are dual cured. Because of the bioactivity, you know, they're desensitizing, and because of the rubberization of the material, we're seeing excellent wear. And so a lot of the technology that we built into this product is proving itself out. But the main thing we were going after was to make it easy to use and create, if you will, time savings in the use of this material as well. But more importantly, again, we're looking at longevity. And so stopping micro leakage, all the things that John's been talking about here, about how do we get the bugs out and seal those restorations is first and foremost on our minds. Activa wears well. This test is done at the University of Alabama with Dr. John Burgess. This test has been replicated 3 times by Dr. Burgess, and the results are the same. Activa wears as well as the best composites in dentistry. Also, toothbrush abrasion with the most coarse toothpaste material, Arm & Hammer, and the most kind toothpaste from Colgate. You'll see the wear factors where Activa Restorative wears as well as Beautifil and Tetric EvoFlow. We're quite proud of this, that the material, even though it's rubberized, it not only wears well, but it also resists abrasion quite well too. I placed this slide in here just for basically comparison's sake, so that you could see that the physical properties of Activa Bioactive Restorative actually compare well to Filtech Supreme, and how it compares with Keytech Nano, a resin-modified glass ionomer, and Fuji 9, a glass ionomer. You'll see that the compressive strengths are in line with the composite material. The diametric tensile is in line with the composite. The flexural strength, a little bit of a difference, but where we really want to focus, and really what is the most important, is the modulus. Because what we're really trying to do with the rubberization of Activa is mimic the function of dentin, and that is the ability to absorb shock. The ability to absorb shock in our minds, especially for the company I work with, Pulp Dent, is to protect the pulp. We like pulps. And that's why we like glass ionomers all these years, because it has a modulus that's very close to that of dentin and has done a very good job of protecting pulps as well. So you can see it's about half that of the composite materials, and we're very proud that we're reaching closer and closer to that of the natural function of tooth in the physical properties of these materials. This was presented at the most recent IADR meeting by Dr. John Powers and Dr. Michael Miller, talking about the amount of voids in dental materials. And voids are your enemy, and voids are our enemy as well. Voids can affect the proper setting of the material, and they can set up physical issues within the preparations themselves. And so we try to avoid bubbles at all cost. I go to a lot of lectures, probably like you do, and over the years, I sort of got tired of looking at one composite compared to another composite, or composites compared to gold, or porcelains compared to ceramic, other types of ceramics, and I often wondered why we never compared our materials to what we had in the beginning, which was perfect. And so I made this chart to compare materials basically to tooth structure, and how materials do compare or do not compare whatsoever to the tooth. And that should be our goal. Our goal should be to, try to achieve what we lost. That's essentially what we're trying to do. We're trying to give the patient back what they lost. We like to say, in bioactive terms, we want to give them back the calcium and the phosphate they lost, but in this way, we're also giving back a functionality, if you will, that is something that's quite natural, that is comfortable in the oral environment. It's not fighting it, it's existing in it without changing the balance of life. And so biofilm is part of the oral environment. And Dr. Jack Farrakhan at the University of Oregon for over the last 6 years under an NIH grant has been studying the effects of biofilm on our restorations. And John highlighted this earlier in his presentation, pointing out how important it is to realize that the acids that biofilms contain can literally degrade the margins, eat into the composites. It's a common saying in the research world that biofilm will eat composite. But once it happens, and what's being illustrated on the left image is once that gap starts to open, then through hydrolysis, the biofilm is able to make its way down the gap. And eventually, as John talked about before, was how that biofilm, once it gets to the dentin, is when it really does its harm. And so what there are materials on the that are on the market and coming onto the market that are talking about how you buffer these biofilms. And one of the things that I find consistent with the researchers around the world is that it's not about changing the oral environment, it's about being able to be natural in the oral environment. Because just like bacteria, there's good biofilm and there's bad biofilm. You don't know which one is which. So the image on the right is showing Activa after the same thing has been done on every composite in dentistry, is showing that the biofilm still forms onto the surface, but not very well. And a recent study that Dr. Farrakhan published at the IDR showed that, that the ability of Activa to retain biofilm is about the same as bioglass. So it's not very well. It can be easily removed. Whereas with dental composites, biofilm attaches rather very significantly and is difficult to remove, as many of you know. What you're looking at is, you'll see an interdiffusion zone in the square. And that is something that Dr. Farrakhan and Dr. Hilton told me at the time they presented this information to me, that they'd never seen this before. And really what you're looking at is the diffusion of the ions from the Activa into the interface of the tooth, and starting to set up its nucleation and diffusion aspects and ultimately mineralization. What you're looking at now is from Dr. Franklin Garcia Godoy, the University of Tennessee. This paper was also given at the IDR in 2016, is showing how Activa's resin, and the resin is bioactive, can penetrate into the tubules, and once it's in the presence of moisture, will start to form apatite, a calcium phosphate type apatite. And so you're looking at a very uniform layer across the dentin. And in fact, many of the researchers who have tested Activa for MMPs and other things have all told me the same thing, that it always leaves a very uniform coating. You very seldom ever see porosity in that coating on the dentin. And so once it's polymerized, you'll see that there's sort of these resin tags emanating from the dentin. We're going to talk a little bit more about this and how Activa is actually functioning in the dentin and on the dentin as we go. So this is an illustration that we made recently. I just came back from Europe on another research trip, showing Activa being placed on a demineralized tooth rather. And again, this is an illustration. You're seeing the interface between Activa and the tooth. And Activa has a high concentration or a high energy level of calcium and phosphate, whereas the demineralized tooth, of course, has a lower concentration. But what's happening is because of the hydrophilic resin that Activa has, the ions are able to diffuse with the tooth until equilibrium is reached. And once this equilibrium is reached and you find this balance, the tooth is satisfied. Activa is not losing anything, it's just giving away what it has in excess. So what happens after that is a nucleation sites are forming along the surface of activa, and the ions from the tooth will form on the nucleation sites of activa and start to mineralize into the tooth. And so it's different than bioglass that is precipitating these crystals. We're actually attracting the ions, the calcium and the phosphate ions from the tooth to activa, and those ions are what are forming the crystals. So in this case, many companies, we like to all talk like we're the answer. Here's what we did for the tooth. Well, really all we did was create these nucleation sites that invited the tooth to be a part of the process. So it can't be any more natural than that. And so back to the Franklin Garcia Godoy slide, exactly what you're seeing here is the ions that formed on the surface of activa are now crystallizing and forming the mineral elements.
I'm going to show a couple of clinical cases now. And again, the remarkable thing regarding the Activa material is not only its ease of use and the number of years that I have been using it, it's what it does to help the tooth as we go forward. And again, sensitivity can be significantly reduced. This is a case that I saw back in February of this year, and as you can see, the composite is failing. And radiographically, I don't know what's going on interproximally there, but that certainly didn't look like a very successful restoration, and that tooth was bothering the patient. So we went ahead and we removed the restoration. I use Isolite as an isolation device in my practice, and I always pre-wedge as well to try to reduce the type of problems that you would have if you nick the gingival tissue. So we removed a majority, if not all, of the underlying structure, got down there, and then I placed a new novel pulp protector that is going to be available sometime in the near future that contains calcium and phosphates and adheres to structure and is able to really release calcium and phosphates to help with pulp protection and pulp improvement and health as we go forward. And so the slide on the right shows that new novel material that we started using and testing at the office. And that is Activa rebuilding that entire tooth structure on the left. And radiographically on the right, you see the Activa material and that novel pulp protector underneath it. So you can see the radiopacity of this new material in conjunction with Activa. So that was the immediate post-operative radiograph that was presented. He came back in a few months later for recare, and we took a secondary image just to see what was going on back. So after 5 months, the tooth itself is happy. There's no evidence of any radiolucencies, any kind of damage to the nerve or any kind of pulpitis going on. And you can see that after 5 months, this large restoration is still wearing very, very nicely. Clinically, people are saying, well, can you use it anteriorly? I've done many, many cases with this material anteriorly, and this is one of the ones that I did not too long ago. A lot of on the class 5 region that actually went into the interproximal space. As you can see on the left, the preparation there, the pre-wedging, of course, and again, under Isolite. We went ahead and we restored this using Activa. We placed our mylar strip into the area and then just filled the material into the tooth, creating the bicuspid in the canine and this class 5 restorations, and even the restoration on tooth number 10 on that distal. And after polishing with traditional polishing material, wheels, etc., soft flex discs and polishers, you're able to get a really beautiful luster, pretty comparable to most of the other types of composites that are out there. This is a case that was recently shown on Materials Group website and Facebook page that I'm on that's open to all dentists that are interested in learning more about these biomaterials and research in general. Is the Dental Biomaterials Group. You can just look it up and and asked to become a member. We're always entertaining more people. We've got almost 13,000 people worldwide contributing, but this particular case was done by Dr. Corrado Caparossi in Italy, and he isolated the area using, of course, rubber dam. And the other cool part is that he used the AquaCare or the AquaCut air abrasion unit to create this very conservative braided tooth structure. Really nice product. He used, in this situation, a bioglass called silk to cut the preparation. And then he filled the restoration with Activa in a very conservative way. And all of both molars were done with the air abrasion and restored with Activa. So again, it can create such really wonderful restorative procedures there, material. And lastly, I'm going to finish up at least case presentations with the longest Activa running case that we have right now. This was back in December of 2012 when the material was first introduced to me. We have that failing amalgam on the lower, on that bicuspid, that also had a crack on that mesial margin. So we opened up the tooth and we flared out the occlusal using, again, David Clark's methodology to try to create what we call an infinity edge around the restoration. And we filled the tooth with Activa. We then did some follow-ups, and after 49 months, the restoration, it was holding up spectacularly at that point in time. Even at 53 months, we still have a really nice result. There's no breakdown, there's no marginal leakage. The tooth is in function. It's in function all the time against the opposing teeth. And again, it's holding up well. And at that point in time when I did this restoration, I really didn't put a lot of effort into polishing it because I wanted to see what it was going to do. The neat part is it kind of self-polished itself over the course of time. And this is the unique aspect with the Activa material. It can work beautifully in the oral environment. The hydrophilic resin of the Activa material is what makes it unique and special.
Yes.
It holds the ions and it holds all of, it's a reservoir for the teeth to use to help self-heal over the course of time. And that's the beauty of using this material.
A man that I truly respect in the United States, and actually he's truly respected around the world, is Dr. Jack Farrakhan at the University of Oregon. And he recently, as an editorial, wrote this for the Biomaterials Oral Health magazine. And I'm going to read it to you because it's honest. And it's really what's happening in the world right now and the changes that are taking place. He says that biomaterials for use in the maintenance of oral health are developed at a rapid pace, while the dental practitioner will continue to use synthetic biomaterials to provide care that includes the prevention, restoration, and replacement of lost or missing oral tissues. The future promises exciting new developments. In the future, the desire for biomaterial to be inert, non-harmful to the patient, while still relevant and necessary, will no longer be considered sufficient. New materials currently being introduced, under development, or simply envisioned are expected to be bioactive, in that they will be intended to interact in some positive way with the oral environment. These materials will provide a wide range of diverse functions, including the routine inhibition of bacterial biofilm formation, remineralization of lost dentin and enamel, and the regeneration of diseased pulp, bone, and soft tissues. The dental practitioner of the future will continue to be exposed to less traditional materials and methods in their daily practice. Rapid and significant advances in science and technology will provide real techniques and methods that only were dreamed about just a few short years ago. The intent of this compilation and this review, the current state of the art in biomaterials for oral health, while introducing the developments that will continue to transform the field and the practice of dentistry.
And that's the purpose. The purpose here is to continue to expand our horizons, to not sit on what was, but we need to move forward and use what is. And hopefully with the vision of companies like PulpNet and the researchers around the world who are continuing to look for better ways for us to take care of our patients, we're going to be able to really make a difference as time goes forward. And you, the audience, have that opportunity. You need to question what is going on right, why your materials aren't succeeding to the degree that you'd like them to, and ask and find better ways of helping our patients because they look up to us to help treat them and to keep them healthy. And hopefully, this is a small step forward into making that a reality.
Yeah. I just want to say, that right now PulpDent is, mainly the only player in the bioactive restorative market, and that's why you generally just saw this material tonight. I don't want to discount glass ionomers.
Right.
I come from a long line of glass ionomer, and we're not knocking anybody. We're just saying that there's new technologies available now. There's new ways to mineralize, and that's what we're looking for. We're looking for the benefit of the patient more than anything else. For us, it's not about market share or anything like that. We're truly trying to do something that will benefit the patient all around the world. And that's how we look at things.
Yeah, glass ionomer and resin-modified glass ionomer is my first loves in dental materials, simply because they could do things that regular composites couldn't do. And they still are extraordinarily valuable in a lot of things that we will accomplish as clinicians. But we still need to see that there are other materials that could be substituted in and actually make things work a little bit better for us as we go forward. So we have now come to the end of this presentation, and we do hope that it has been informative to you, and hopefully we gave you a little bit of information that you didn't have before. And I guess we're going to go to the questions that are now starting to pile in. So thanks so much for them. We'll go through things. Let's see. There's a comment about mixing tip for, I'm not sure what that is. Hang on a second. Your comment about mixing tip for something. In deep restorations,
use Gluma.
Use Gluma, okay. I'm trying to read this question. I'm not actually getting it. My apologies. We'll try to figure this out back in here. Let's see.
Question.
Yeah, I'm not sure.
Tap on it, does it go over there?
Maybe it does. Let's see. Okay, good. You comment about mixing tip for Activa seems to be we lost a quantity of material inside it. That's an excellent question. Actually, you're not really losing much material at all within it because like a mixing tip, any kind of a thing, the material goes around it, but what you're seeing is the coating on the outside of the material, not necessarily outside of the mixing tip itself. If you were to cut that in half after you've expended it, you'll see there's really not a lot of material left inside of it.
According to the manufacturer in Switzerland, the amount of material left is 0.17 ml.
Yeah, so the mix pack tip is really very effective in doing things. Another question is, can conventional composites be applied over Activa as a final layer to provide better aesthetics?
Yes.
Sure. If you want to do that, no problem with that. And so if you need to do those regions, there's certainly no reason why you can't. Let's go back to some of these others here. How long do the ions pass from Activa to tooth when there's a bonding agent between them that acts as a barrier? Well, that's an interesting question because, as we talked about, the bonding agent is going to degrade over a course of time. So Activa is actually, as soon as that breakdown in hydrolysis starts, Activa ions are going to be able to penetrate, and that's been shown on several SEMs.
Also, the study that was done at Tufts, they used varying different types of bonding agents. They used the more hydrophilic fifth generations all the way up to the new universals. And the only difference in the amount of time that it took for the ions to go through was maybe 3 minutes.
Yeah.
you know, the ions are going through, because you have to remember the bonding agents are porous, and they're also hydrophilic, so the ions are freely passing through.
Next question, what are your thoughts on Carey's indicators like Snoop? Basically, there's been some studies that indicate that these Carey's indicators are actually interfering with the bonding agents. So I'm not a big fan of it. If I have a question, if there's decay, I'm going to use something like a Smart Burr 2 from SS White. It's been my go-to to try to remove infected and leave only the affected dentin there, which from a bioactive and biomimetic aspect is going to allow that bioactive material to really penetrate more effectively in there. So that's my personal opinion. Some people would disagree, but that's okay. Okay, let's see, where are we? Let's see, where are we? We have some more questions here. There are quite a few actually, which is great. Can you discuss time savings and learning curve? That's great. Time savings, actually, once you get through the learning curve, and there's a small learning curve because of the viscosity of the material and the ability to apply it. You need to make sure that during the application of the material that you keep the cannula of the mixing tip in the material the entire time. Do not take it out and push it back in. You'll create air voids. And you want to fill from the bottom of the deepest portion of the preparation up, backfilling essentially. It's very quick because you're not going to have to worry about a bonding agent typically if you don't want to use a bonding agent. I haven't used a bonding agent with the material for quite a while, but you do want to let the material sit in the tooth for approximately 20 seconds from the initial application before you light cure. And light curing should be done for 20 seconds. Make sure that you know what the energy level of your light is to make sure that you're getting proper cure. Even though this is a dual cured material, it does take several minutes for that dual cure activity to occur. So please light cure it properly or allow it to set in the tooth for the appropriate amount of time, which is 3 minutes. At body temperature for it to completely set. If you remove the band or you don't give it the opportunity to set completely in the dual cure phase, you will have mush. That's not a good thing. So make sure that you allow full curing to occur. That's really very important. But there is time saving and there's money savings as well because you don't have to worry about bonding agents typically. Another question, in deep restorations, I use Gluma. Does this adversely affect the bond tooth interface? That's a question that I was asked the other day by a colleague of mine at the university. And basically, I look at Gluma as a mummification process.
Yes.
And it interferes with everything because you're basically competing with the material, with the resin, to try to get into the dentin tubules. So I would highly recommend against the use of it. I don't think it's a good choice. Personally. Let's see, we've got another one. By my definition, a GI is bioactive with fluoride release. By the definition of Steve Jeffries, it is not bioactive according to the Jeffries definition because fluoride doesn't necessarily, unless it's in the right environment, form apatite. You need calcium and phosphates. If you have calcium and phosphates, you can form apatite. If you have fluoride in the presence of calcium and phosphates, you can create fluorapatite. Yeah. But that's the combination that needs to be. Fluoride by itself will not create fluorapatite.
The literature, though, going back decades, has referred at times to glass ionomers as being bioactive. So from the
original definition.
So we're not in denial of that. It's just the definition has gone back to the original, both from Larry Hench in 1969 and now Steve Jeffries.
Yeah. So that's why in the new definition of Steve Jeffries, you need to form apatite to be bioactive. Let's see. You spoke a lot about dentin bioactivity and thus bonding, but I'm confused on how Activa bonds to enamel. Basically, the resin bonds to the enamel as you etch the tooth. You're opening up the enamel prisms, and you're going to be able to flow that resin into the enamel in the same way you would do with any other adhesive and composite bonding system. So it works the same way.
And the demineralization. You know, the demineralization is also taking place when you etch, and it's in essence making it hungry for the ions that Activa is going to diffuse.
And it's going to create apatite enamel in the same fashion.
Yeah. That's why we hardly ever, we've never seen staining at the margins in the enamel in my 5 years of being involved with the material.
Another question is, the doctor states, I think bioactivity materials are great in everything, but I kind of see that it gives aesthetics inferior to that of composite and shouldn't be that of great concern. Again, from my experience, I can get a very nice aesthetic result. But for those of you who are really aesthetic, you might want to coat it with something, but
Yeah. Dr. Nick Opdan has done a lot of research around the world about why restorations fail, and he concluded that in a most recent study done in South America that posterior resins are replaced because of caries and because of breakage.
brutal.
Anterior restorations are replaced because of color change. And so this is where the patient actually starts being involved in the, gee, I started out with a B1, now I have an A3, what did you promise me? So here's what we see happening in the future is the more not just our company, but other companies are studying the effects of these minerals, they're seeing that they're far more color stable. And we're seeing it in materials that are yet on the market. And so we think the future is bright for anterior restorations and to be bioactive.
Another question, after mixing Activa, how long is the working time to calculate can be applicated for a couple of teeth? That is an excellent question, and you do need to be, depending on how many teeth that you're working on, you do need to be rather swift in what you're doing, because after a few minutes it will start to auto cure from the ambient light around you. So what my assistant always did, she always had a few extra mix packs tips available, ready to go after I start to find that it's starting to become more difficult to express. But you've got a few minutes, and as you become more familiar with the material, you'll know when you're going to need another tip, and your assistant will do so as well.
We've learned also from the pediatric community, especially working in the OR, they have their assistants tape the tips before they go in the OR, or else they cover the dispenser tip with something while they're working.
Yeah, to try to prevent that auto-polymerization.
Yeah, just try to keep the light away from the tip, and it will last longer.
Another question, which releases more fluoride, glass ionomer or resin-modified glass ionomer? GI always does. The resin doesn't allow as much fluoride release as does a pure glass ionomer.
And I'd like to say something about that also, because when we first put out our first white paper, we talked about fluoride release, and in that case it was greater than the glass ionomers that were being tested at Tufts Dental School. But that was really a diffusion of ions test. It wasn't just a static put the materials into a beaker and measure ion release. It was actually, there was a separation of the ions from distilled water. And so the ions had to actually pass through the material to get to the distilled water and then be measured. So what we're actually saying here is we diffuse more ions. That doesn't mean we have more ions to give. And so what happened really in the testing was that the glass ionomers dissolved over time, and that's why they fell off on the, and I feel a little guilty about this, because that wasn't the intent of was to say we have more fluoride, because we're actually using fluoride just the way the tooth does. And it's simply, you only need a little bit of fluoride to expedite the binding of the calcium in the fluoride, or calcium in the phosphate, and then make a more acid resistant material. And that's what we have.
We're running low on time, so I'll try to get to a few more here. Question is, do you need to etch and bond the Activa if you put a layer of composite over it? Yeah, you would be doing that. Next question, what do you polish the Activa? I've been using traditional composite polishing instruments. There's a whole bunch of them that you can use, whatever your preference is to get your greatest luster with. Hi, John. The question is, the base the new product Pulp Dent is coming out with, or is there a change to Activa coming?
No, there's no change to the Activa, but there is a second generation of Activa coming.
All right, we're just about done. Last 10 seconds. Do you etch the tooth if you don't use a bonding agent? Yes, you always etch the tooth. That's what the IFU will tell you to do. All right, 3 seconds. Thanks, everybody. Bye.
Bye.